Sara Luby, and I am a nurse scientist in the Munn Center for Nursing Research and a clinical investigator in the Metabolism unit here at MGH. So, who doesn't love sweets? Well, my program of research evaluates nutrition and metabolic and heart disease complications in people with HIV. And there's an old saying that you are what you eat. And for those living with illnesses, including HIV, eating too many sweets or added sugars each day over time may seriously impact overall health. Let me tell you why. There are natural sweeteners like something called fructose found in fruit that are healthy. And then there are added sweeteners like high fructose corn syrups that are added to baked goods. Early research studies have shown that people with HIV tend to eat more added sweeteners than recommended and have poorer diet quality compared to similar people without HIV. Also, those with HIV have a greater risk for heart disease than those without HIV. And one study showed that increased intake of added sweeteners led to something called coronary plaque, or a buildup of fat in the arteries that feed the heart, leading to heart disease. Here, let me show you what this looks like. What you're looking at here is a healthy artery or blood vessel leading to the heart, where blood can travel seamlessly down to perfuse the heart so it can pump to the rest of the body. However, plaque can form from an artery if a person eats too much fat, has bad exercise habits, or smokes, or sometimes because of family genetics or different illnesses, this can happen. And when this happens, the arteries get clogged and the blood can't perfuse to the heart. So add to this too much sugar in the diet, and now we have a real problem, which can lead to heart disease. So given this information, it's very important to better understand factors that may influence added sweetener intake in this population to create feasible and sustainable nutrition interventions. So in our study, we evaluated knowledge and intake of added sweeteners in people with HIV and explored association of these factors with age, race, sex, education, income, and access to fresh fruits and vegetables. We looked at the influence of these social demographic characteristics with sweetener knowledge and intake. How do we do it? We conducted a US national survey by advertising on websites frequently visited by people with HIV. We had 900 people from 46 US states complete the survey. Findings from our statistical analyses showed, starting with sweetener knowledge, that female sex, being of diverse racial and ethnic background and having less than a high school diploma, significantly associated with lower sweetener knowledge score. In terms of sweetener consumption, being of diverse racial and ethnic background, younger age, having a higher weight or BMI, lower income, reduced access to fresh fruits and vegetables, and lower sweetener knowledge score, significantly associated with higher sweetener consumption score. Findings from our study highlight the need for consideration of specific demographic and inequitable social circumstances when developing nutritional lifestyle strategies, something I am very passionate about. Thank you for your time.
Excellent, Sara. Yay, everybody give her a big round of applause. Okay, Sara was our first one, but she's going to be a tough act to follow. Lovely use of props. Love the props. Very nice. Excellent, excellent job, Sara.
My name is Jennifer Duran. I'm a nurse here at MGH in the newborn ICU. My work recently in global health has taken me halfway around the world to a remote area in Uganda. The purpose of this fellowship was to assess the educational needs of the staff working there. As I acclimated to my new surroundings, it was hard to ignore the numerous babies that were dying as a result of being born prematurely, and this weighed heavily on my mind. So I focused my efforts towards understanding the problem. You can't find a solution to a problem until you know exactly what the problem is. A little background. 3 million babies die each year around the world from being born too early, and where these babies are born certainly impacts the outcomes. In Uganda, you are 7 times more likely to die as a preterm baby in comparison to the United States. The resources simply are just not there. Upon returning home after this first fellowship, I began my work on a new educational program aimed at reducing the newborn deaths in this hospital. Additionally, I developed a CPAP device to return with to begin the initiation of this life-saving therapy. So what is CPAP? CPAP stands for Continuous Positive Airway Pressure. It offers the opportunity for a preterm baby's lungs that look like this to look like this. This is a fully inflated lung. This is about all I have for props compared to Sara. That can help sustain a newborn's life. Babies born early lack the ability to keep their tiny lung sacs open. CPAP affords this opportunity, thus increasing newborn survival. This device was created to function off a simple water-filled jar, like this one that I have here, using oxygen or any compressed gas to create the pressure. These small prongs, you can see my little baby, sit comfortably in the newborn's nose to allow for this pressure to open up their fragile lung sacs. I was careful not to consider potential solutions requiring electricity, as this is a resource that is at times not available and quite uncomfortable for the nurses working. Today, staff continue to increase confidence in managing these preterm babies, as well as decreases in mortality, which is encouraging. What's unique about this project is that this is solely a nursing education initiative and a quality improvement project. MGH has a long relationship with this hospital in Mbarara, Uganda, but this is the first newborn ICU project. What I've learned about this work is that education is the resource that can never be broken, lost, or taken from us. It empowers us to seek solutions where there appears to only be problems. This work is rewarding on so many levels. Thank you for your time.
That was really great. I'm getting a lot of feedback. Everyone else? Okay. Love the lungs. Excellent use of props too. Balloon lungs. Love that. And I really loved what you said about how this is a nursing education thing, like the nurses are making such a difference in that hospital. That's really awesome.
So my name is Gailvie. I'm a staff nurse in the emergency department, and I've been here 36 years. I am #1 in my department out of all the nurses for seniority, out of 280 nurses. I've had multiple roles, and most recently working with the post-discharge calls, which I love, and I love this kind of work. So anyways, I'm going to begin. So has anyone ever been a patient in the emergency department and then discharged home and then wondered to themselves, what do I do next? What is next? And you think to yourself, oh my God, I've been there so long. I'm tired, I'm hungry, I'm thirsty. I couldn't have any food because of all the tests that I needed to have done. And then when the healthcare provider reviewed my instructions, I just couldn't comprehend. I couldn't understand, and I really just wanted to go home. And I really don't want to go back to the emergency department. But then all of a sudden, the next 24 hours, you get a call from an experienced RN that provides a post-discharge call. And then you think to yourself, wow, this is really great. The RN reviews the ED visit and the follow-up. They ask how you're doing. They provide reassurance, reinforcement, and resources. The RN explains how important it is to follow up with your provider and all the many benefits that occur from that. The RN can provide specialty and contact numbers that you may need. The RN can also help with referrals to things like the virtual observation unit or the partners mobile unit. These are all alternative pathways so patients don't have to come back to the emergency department. The RN can also help facilitate appointments. They collaborate with other healthcare providers, such as doctors' offices, and they can help with any barriers or challenges that occur with the follow-up. And they also provide these three-way calls with non-English speaking patients. They even offer a HIPAA certified volunteer phone call 72 to 96 hours after the RN discharge call. And this volunteer sits side by side with the RN and basically just provides a reminder phone call. There's no medical advice that's given by this volunteer. The volunteer has a script that they utilize. And if there are any questions or challenges that occur, the RN is right there and can deal with it in real time. With our project, we took a sample size of about 380 patients upon discharge, and we found that only about 48% of them really knew what to do or who to follow up with. So with that project, what we did was we included a modification to this nurse-led discharge call by adding a HIPAA certified volunteer to help increase the follow-up with their providers from 48% to over 60%. And we were hoping with increasing follow-up, we would get decreased revisits and hopefully things that affect these capacity challenges hopefully wouldn't be as bad. So what I'm going to do basically is just give you an example of how these calls work. Basically, I would call the patient, RN. My name is Inez. I'm a discharge call nurse. I'm calling from the emergency department to see how you're doing since your recent visit. And I want to help you with your discharge instructions and make sure you understand what you need to do. Patient. Oh, thank you very much. I really appreciate this. I was wondering what to do. I was scared. I wanted to get out of there. I really wasn't paying attention. I'm glad you're calling me. I don't even have the discharge instructions anymore. I lost them. There were so many papers. I think I threw them away. So I'm glad you're calling me and trying to help me. I don't even think there were contact numbers on the paper. RN? No problem. I can help you. We can help you with all of this. We can review your instructions, review your visit, give you the contact numbers. We can even provide you with a volunteer over the next 72 hours to call you again and help remind you to follow up with your provider. And if you have any problems or challenges, we can certainly help deal with that. Thank you very much. Thank you very much. I'm looking forward to all this information. I appreciate you calling me. Mass General must really care about their patients to have all this concern. Volunteer phone call, 72 to 96 hours afterwards. The volunteer basically states, hi, I'm a volunteer from Mass General. We're calling to help remind you to follow up from your emergency department visit. We care about you, we care about our patients and want them to get the best possible care. And that includes following up with your provider. Have you followed up with your provider? And would you like to speak to the RN if you have any more problems? He or she is sitting right here next to us. And we found with all of this, our patients really loved these phone calls. They thought we were the best thing since sliced bread here at Mass General Hospital. That's it. Thank you.
Excellent. That was excellent, Inez. So important. It seems like I can't believe we haven't always done it, right? It seems so great, and I'm sure that you guys make that all of the patients feel so important. How many do you have trouble getting in touch with people? Usually out of the phone calls, we probably reach 3/4 of our patients. So we do make 2 call attempts, and then once that's done, the call gets dropped. And I do want to mention, I forgot to mention that if anybody wants to look at any of this data, we published 2 articles, Journal of Patient Experience and Journal of Emergency Nursing. All the details are in those articles. Excellent. Congratulations on
that. With the help of Jen Cahill, of course. Jen Cahill was instrumental in helping me with that.
Great. Really, really great. I love hearing about all these nurse-led initiatives. The research that goes on is so important.
So my name is Liz Mover, and I'm a staff nurse and the attending nurse in the medical ICU on Blake 7. And I was lucky enough to participate in the AACN CSI Academy. And we identified a problem on our unit and really in all ICUs, and kind of came up with a way to fix it. So I'll be talking about using weighted blankets in the intensive care setting. Imagine being in the intensive care setting with an endotracheal tube, also known as a breathing tube, down your mouth, and you can't speak. You're on multiple sedating medications and you're on them for days. Your medical team decides it's time to stop your sedating medications, wake you up, and take that endotracheal tube out. Your nurse puts restraints on your wrists so you won't pull your tubes out, and then turns the sedation off. You begin to wake up. You don't remember where you are or why you're here. You're disoriented. You may even think you're on another planet. You start to squirm around, you get agitated, and you don't know why you're here. Your medical team decides to give you a small dose of medication to keep you calm. You become unsafe in the bed, and you're at risk of pulling things out, lines, tubes, and other devices. Your medical team decides to fully resedate you. How can we make this process better for our patients? In the medical ICU, we trialed using weighted blankets. I'm going to put one on. Sorry, they're really heavy. So trialed using weighted blankets on our patients who are ready to be extubated and have their sedation turned off. There's limited research on weighted blankets in the acute care setting. One thing we do know is that weighted blankets help ground a person. They help increase reality orientation, self-soothe, calm a person, and provide comfort. Weighted blankets can provide warmth, deep pressure, tactile and visual stimulation. They create a feeling of being held. Who doesn't love a good hug? We identified patients daily who were nearing extubation, so meaning taking that breathing tube out, and who are ready to have sedation weaned down. We asked the nurse to apply a weighted blanket before weaning sedation. We found that the blankets were helpful in our patients who were also agitated, restless, and we found that our patients moved from a restless state to a more calmer state. We actually had a decrease in about 22% decrease of using our continuous sedating medications. And there was a 51% decrease in using as needed medications. We also found that patients came off the ventilator sooner. We decreased our ventilator days from 5.3 days to 4.8 days. Patients told us they felt safe with the blanket on, they felt comforted, and nurses felt that their patients were actually able to sleep better with the blanket on. So to recap, using a weighted blanket on your patients who's coming off sedation and who most likely are confused, restless, agitated, and scared might help keep the sedation off and get that breathing tube out sooner and get them home sooner. Thank you.
Excellent work, Liz. Again, such a straightforward thing, such a straightforward issue. How long have weighted blankets been around? How many people have them at home? People have weighted blankets at home? I see hands up, right? Somebody wrote, I love my weighted blanket. So I see them in the stores all the time. I've never actually tried one, but this sounds like a remarkable use for them. So again, just an observation from watching patients and such a incredible research project. So thanks, Liz, for presenting to us today.
So my name is Kirsten Dickens. I'm the Cannell Postdoctoral Fellow in Nursing Research at the Munn Center, and also a nurse practitioner in the Home Hospital Program at Mass General. Today, I'd like to share with you some thoughts on the big question that drives my work, which is, how do we ensure that all people have a fair chance to live a long and healthy life? My unique approach to answering this question is to use numbers and human stories to see trends in large data sets and to understand what these trends mean to a patient's daily life. From 2015 to 2019, I was a PhD student in Chicago. Go Sox, Cubs, Bears, Bulls, Hawks. I also worked as a nurse practitioner in the various homeless shelters across the northwest and south sides of the city and the Cook County Jail. I saw firsthand the inequities and what it means to live a long and healthy life. You may have heard the term zip code disparity, or the idea that life chances differ quite literally block by block. Zip code, used as a proxy for all of the social factors that impact a person's life, is now recognized as more important in determining health than genetic code. Health is not the result of solely one's genetic makeup, but rather the conditions to which one is exposed on the daily. In the distance of just 1 mile, your life can be expected to be shorter or longer by 10 years, depending largely on social conditions, poverty, racism, ageism, sexism. Social conditions profoundly impact one's chances to live a long and healthy life. When I moved to Boston strong, I wanted to delve deeper to understand what it looks like in a homeless population, and more specifically, in homeless women, a group on which little research focus has been placed. Let's start with a reference point. In the general population of the United States, the average life expectancy at birth is 78 years. For men, it's 75 years. For women, it's about 81 years. For my study, I looked at a group of over 60,000 homeless persons in Boston from 2003 to 2018. In this group, over 7,000 homeless persons died. The average age of death in this cohort was only 53 years of age. In men, it was 55 years of age. Women, on average, died earlier at around 50 years of age. In other words, homeless women died on average over 3 decades prior to the average female life expectancy in the United States. About a third of deaths were substance use related. The next leading causes of death included cancer, heart disease, and liver disease. These disparities were so tough to understand, so I sought stories to fill in the details. I talked with low-income women and homeless women about their unique strengths and challenges. Women shared their stories of fear, of mistreatment, of trauma, and also the incredible resilience within this struggle. One woman shared, quote, "I've fallen so many times in my lifetime. Added on to that, the loved one's death, but still, I rise." The task now ahead of me is to use these numbers, and again, stories, to develop solutions that promote equity and opportunities to live a long and healthy life. It is the idea or belief that this is in fact possible, the dismantling of disparities and the creation of systems and contexts that promote equitable health outcomes. This is what keeps me both motivated and also still in love with my work. With numbers and stories, we can promote equitable life opportunities that can be experienced fairly across all members of society.
Thank you, Kirsten. That was awesome. Very, very important work, very moving. I love the move from Chicago to Boston, and it's really great for the volunteer that we have you and that you're undertaking this important work. And I'm a geneticist, so now I loved your zip code is more important than genetic code when it comes to living a long and healthy life. You know, as a geneticist, I would think genetic code is the most important thing, but I learned something today. I'm learning a lot today, actually, from listening to all of you, but that was really important. I think it's a really important message. So thank you for choosing to do your work here. It's really remarkable, really remarkable.
I'm Rebecca Hill. I'm a nurse researcher and associate professor at the MGH Institute of Health Professions. And my research is all about tongue tie. It is a minor congenital oral anomaly that can have significant consequences. So we found that it occurs in approximately 8% of babies. And when it's present, you can see here the tongue. This is the extra tissue under the tongue that adheres the tongue to the floor of the mouth. So when that tongue tie is present, the tongue cannot lift appropriately. When the tongue can't lift, there are issues for both the baby and the mom in terms of breastfeeding and infant feeding in general. The research to date has not provided a strong enough argument to create any universal screening guidelines for tongue tie, and I hope to add to the research and provide sufficient evidence to support that this mild anomaly can have significant implications for moms and their babies. So to date, my research has focused on trying to improve our understanding of the symptoms that babies and their breastfeeding mothers may encounter if tongue tie is present. What I've found so far: for mothers, breastfeeding is more commonly a very difficult and painful task. Mothers are more likely to experience pain when the baby latches onto the breast. She's also more likely to develop cracked, creased, blistered, or bleeding nipples during breastfeeding. This relates to the baby's inability to lift that tongue, so they end up biting rather than sucking on the nipple or creating additional friction onto the breast. Mothers frequently need to use a nipple shield or switch to bottle feeding because of those difficulty symptoms. I found that these symptoms are significantly reduced almost immediately after the tongue tie is corrected. Mothers have also experienced more stress and reduced bonding with their baby when feeding is difficult. And the longer they experience those negative symptoms, the more stress they experience. For the babies, the symptoms that they have indicate that their eating is really not efficient. I've found that babies are more likely to tire easily with feeding, have more symptoms of problems in their gastrointestinal tract, such as gas, reflux, milk leaking out of the sides of their mouth, frequent spitting up, and overall discomfort. This happens with both breast and bottle feeding. I've also found that babies must work harder to eat when they have a tongue tie. So their strength of their suck is actually greater. They need to work harder and they require more energy to get the nutrition from their breast or the bottle, and they tire easily when they're eating. This research is in its infancy, no pun intended, And we are working towards a better understanding of feeding mechanics when a baby has a tongue tie, so that we can develop a comprehensive screening tool that takes into account the symptoms that both the mom and the baby may experience with this anomaly. Thank you.
Thanks, Rebecca. That was really great. I saw someone put in the chat that they didn't even know what tongue tie was. And so now they've learned about it and now they know what it is. How common is it? Did you say that and I missed it? I apologize.
No, that's fine. Prevalence around 8%.
Wow. Okay, so that's a lot of babies.
Yeah.
And it's not something that they just like do a quick check. Like it would be
Not universally.
right?
So it's really variable provider to provider if it's ever checked for.
Interesting. Well, excellent work.